for premenopausal women? Number 3, what is the impact of adherence or compliance? So first question, what is the optimal duration of endocrine therapy? And for that, we need to know that how we reached at tamoxifen. So years ago, the investigators in the 1970s looked at tamoxifen for 1 or 2 years with a randomized controlled trial versus nothing. And they found that giving tamoxifen for a couple of years was good. Then the investigators thought, why don't we extend it to 5 years? And they found that giving tamoxifen for 5 years was really good. And that's how 5 years of tamoxifen treatment became standard of care. But it was really not based on any actual, the duration of 5 years was not actually based on any hard endpoint. It was not based on any objective data that 5 years is sufficient. It was just a common sense. We just treat for 5 years. We know that in younger women, if you give tamoxifen, the impact is pretty big. You are able to save a lot of women from getting recurrence of breast cancer. So 2 sets of investigators across the world, one from the UK, well actually both from the UK. One of these trials included participants in India also, the ATLAS trial, looked at extending tamoxifen for 10 years versus just 5 years. These are the biggest 2 trials. So what did they show? If you give tamoxifen for 10 years in hormone receptor positive breast cancer, you get at least 3% or benefit in breast cancer mortality. So you are saving lives of women if you extend tamoxifen for an additional 5 more years. Now the key question is, does young women gain the same benefit as older women? And the forest plot, which is sort of the way to look at whether there are any subgroups that would favor treatment versus not favor treatment. And the subgroup analysis showed that all subsets, regardless of whether they were premenopausal or postmenopausal, they gained benefit. Although, please keep in mind, the extra 5 years of treatment, that is total of 10 years, was the impact of that was not very high. It was pretty significant compared to a lot of treatment that we do. There was still a 2.8% breast cancer mortality benefit. And this is the ATLAS trial actually had about 10% of patients who were premenopausal, but less than 45 age, there was about 19% of patients. The same analysis was obtained in the ATOM trial. The ATOM trial also showed that there was significant improvement in breast cancer survival. Now, when you combine the ATLAS and the ATOM trial, you can see that extending treatment, tamoxifen treatment, for 5 more years, you gain overall survival benefit. Now, this is very important. You are actually curing more patients with breast cancer. So, what about letrozole? What about adjuvant letrozole? Let's say if a woman was premenopausal when they come and see you, but during the treatment, they became postmenopausal. So you then decide, okay, I'm going to switch your treatment to letrozole AI, which is only used in the setting of postmenopausal status, versus you are continuing the tamoxifen. Is there any additional benefit? And the MA17 trial showed that extending endocrine therapy and switching to an AI in patients who became postmenopausal, although you start them on tamoxifen at the get-go, actually helps save more women. So now the key question is, so I've now proven once that tamoxifen extending is good. 10 years is better than 5 years. So the question you may think is, would 15 years be better than 10 years? We'll talk about it if you still have that question in mind. But the question that came out of the MA17 trial is, should we use extended AI therapy? Should we extend the aromatase inhibitor? And a bunch of trials looked at it. The result of that bunch of trials that looked at it actually showed that once they actually become postmenopausal, extending the endocrine therapy using an AI for an additional 10 years, a total of 10 years, isn't very important. The benefit is mixed. Some trials actually showed some benefit, some did not, but the evidence is marginal. So in order to summarize this part of my talk, which is remember we are focusing on extended duration of endocrine therapy, not just 5 years, but extending it to 10 years. So who would be that patient who I would think of extending tamoxifen, or if they become postmenopausal, an AI therapy for 10 years? Those who are higher stage at diagnosis, for instance, stage 2 or stage 3, those who have really no toxicity. So when they reach the 5-year mark, I keenly assess the toxicity. If they have a lot of side effects, they can't even handle their pill regularly, then I have a second thought. But if they don't even feel that they're taking an extra pill, a cancer pill, then I would feel like giving them that extra benefit and I'll extend their therapy. I would particularly keep in mind cardiovascular diseases. If they have cardiac diseases, if they have diabetes or metabolic syndrome, I'd be cautious. But again, if they have stage 2, stage 3 disease, I would be less cautious. I would err on the side of caution in extending therapy. If they're younger age is generally considered a prognostic factor. If they're younger age, I would consider extending endocrine therapy. And obviously, from our own experience taking care of patients themselves have some preference. They would either say, "Doc, I'm done. I don't want any more," or "Doc, hey, I'm fine. I get some kind of mental boost. Can I just continue?" But the key question that is asked here at this juncture is there any biomarkers that we can use that can help us understand if the patient sitting in front of you would benefit from extending therapy? And a lot of biomarkers have been assessed. This is just a bunch of biomarkers that have been evaluated. We can look at the reference for more details. A clinical treatment score, that is sort of a staging pattern. The higher the stage, the more the benefit. IHC score also looks at sort of the stage and the biology of the disease. The higher the biology of the disease, the understanding is the more they will benefit from extending the endocrine therapy. But the key thing that I wanted to bring up is genomic assay. So there's something called the breast cancer index, BCI. And if you do the breast cancer index, you may have all heard of Oncotype DX or MammaPrint. That's a 70 gene assay or the 21 gene assay. Similarly, there is a test called breast cancer index. They look at 2 genes, FOXB13, IL-17 index, and something very strange, which I don't understand what it is. It's basically a conglomerate of factors called the molecular grade index. And what they found is low breast cancer index, they have a very good prognosis. And they were also successful in showing that this test is predictive of benefit with extending therapy or not, just like Oncotype DX. Now, most of our tests, it doesn't mean much if we order the test and know the prognosis. It should also help us understand whether it will help the person sitting in front of you. Just telling the patient you're in a bad risk disease doesn't matter. You got to tell them, okay, what can I do to make it better, right? So this test will essentially help us figure out whether extending tamoxifen or endocrine therapy for an additional 5 years will help the patient. Now, I have used this test. I must admit that out of the 100 patients or more that I see, or of similar endocrine therapy situation, I have hardly had need for maybe a couple of patients, this kind of test, mainly because this is very expensive and the decision is rather straightforward. If the stage is high and the patient is tolerating, I tend to continue. If the stage is very low and the patient is having some kind of toxicity, I tend to stop. If the stage is sort of stage 2, the patient is having no toxicity at all, I tend to continue. So in my mind, as a clinician, as a medical oncologist, I'm overwhelmingly bearing on the stage diagnosis, the tolerability of the treatment to decide whether the patient needs to take it for more duration or not, and not the genomic assay. Mainly because this is not a very toxic therapy. Now, if this is a chemotherapy, then I would have some benefit with a genomic assay called similar to breast cancer index. You may have heard of Prosigna, PAM50. Now, PAM50 is another genomic assay that some people may be using. I'm not sure if anybody actually uses in the setting that I'm talking about, which will also tell a person, a physician, whether a patient will benefit from extending endocrine therapy. this PAM50 test or the Prosigna will essentially prognosticate a hormone receptor positive breast cancer patient for risk of distant recurrence or not. And this is also fairly good in terms of predicting whether extending the therapy is good or not. But to be honest, this is my summary slide. What is the optimal duration of endocrine therapy? I basically use risk factors, the traditional risk factors that we use in clinic, stage, tolerability, to decide whether I need to extend endocrine therapy or not. So essentially, I'm going to very much individualize the care to a patient sitting in front of me. Okay, so that is the short, brief summary on the topic of duration of endocrine therapy. 10 years versus 5 years. Who am I going to give that extra 5 years or extra 2 years or extra 3 years? The next question that I'm going to ask is, what is the optimal treatment for premenopausal women? And this is where I want to bring up this early breast cancer clinical trialist collaborative group, Oxford meta-analysis, which looked at ovarian ablation or suppression versus not, stratified by age. What this trial showed was, in women less than 50 years of age, if that woman had some kind of ovarian suppression, they had a significant benefit with reducing their risk of recurrence. Okay, and that is what this meta-analysis showed, Lancet 2007. So this forms the basis of what I'm going to talk about next. This is another trial that gave us some background information. This is the NSABP B30 trial, which looked at adjuvant anthracycline chemotherapy. And what it showed was, if the patient had amenorrhea, that is, you give chemotherapy, you suppress the ovary. Nearly 50% of those women recover the ovarian function. What if a lot of those women do not recover the ovarian function, that they remain amenorrheic? Would they have a benefit in terms of risk reduction? And what this analysis showed was, if a woman who got adjuvant chemotherapy had ovarian suppression that was durable, that is amenorrheic, persistent, they have a benefit in terms of risk of recurrence. So both of these data are very important, because this would form the crux of what we're going to talk about next. And that is adding ovarian suppression to endocrine therapy. This is the earliest trial that looked at it. This looked at tamoxifen in one arm versus tamoxifen plus ovarian suppression. How do you suppress the ovary? By giving GnRH agonist analogs like leuprolide, triptorelin, goserelin, things like that. So one arm will have tamoxifen, the other arm will have tamoxifen plus ovarian function suppression. Remember, I'm talking about premenopausal women. And this trial, remember, this is the good risk trial, okay? Look at all the study participants. Everybody's tumor size is less than 3 centimeters. Everybody is node negative, and it's a small trial. So this trial, I'm not expecting to see much effectiveness difference, but which was what it actually showed. But what it actually showed me, which is very important for our discussion, is quality of life. So this is a very complicated decision making, essentially because of the quality of life. If you look at this slide, the blue is tamoxifen only arm. The yellow is tamoxifen plus ovarian function suppression. The first column here is the cumulative quality of life score. If you see, those who are on ovarian function suppression, the yellow graph, they have an immediate dip in their quality of life when compared to tamoxifen only arm, which is the blue group. At the end of 5 years, both look similar. If you look at menopausal symptoms, that's the column, the bottom C, called the graph number C. Menopausal symptoms, hot flashes, vaginal dryness, all of this. If you add ovarian function suppression, there is an immediate drop in their quality of life when compared to tamoxifen alone. At the end of 5 years, they both sort of approximate. If you look at sexual function, these are young women. We've got to think about their sexual activity too. If you think about ovarian function suppression, the yellow part, the yellow line, it drips significantly. So this is the cleanest trial that we have that looked at quality of life. This is very important for our discussion, for your practice as an oncologist. Okay? So adding ovarian function suppression may sound very easy choice, but it has significant tolerability factor also. So think about that. And it is in this context that two large trials came about. The first trial is called the suppression of ovarian function trial. This is premenopausal women, hormone receptor positive. Whether they got chemotherapy or not, half of them got chemotherapy, half did not. That is totally up to the investigator to decide. What the trial looked at was they added ovarian function suppression to tamoxifen. And one more arm, they actually, instead of using tamoxifen, once the ovary is suppressed, they are postmenopausal women, right? They gave aromatase inhibitor, exemestane. After 5 years of follow-up, what it showed was adding tamoxifen, adding ovarian suppression to tamoxifen was not really very significant. If you look at the 5-year survival, disease-free survival rate, 86.6% versus 84.7%. Small benefit. But now, look at the secondary objectives. Disease-free survival, not much difference. Breast cancer-free interval, not much difference. But now look at stratified by chemotherapy. So no chemotherapy on the left side, prior chemotherapy on the right side. No chemotherapy arm, the blue line, the black line, and the red line, which is black is tamoxifen only, red is tamoxifen plus ovarian function suppression, blue is exemestane plus ovarian function suppression. Absolutely no difference in terms of outcome. Whereas if you look at patients who got chemotherapy, if you gave tamoxifen only, the 5-year survival percentage is 78%. If you give tamoxifen plus ovarian function suppression, you are improving it by 4.5%, absolute. That means you are actually saving a recurrence of breast cancer to 4 out of 100 women. Exemestane, you add exemestane, you are increasing it to 85%. So going up from 78% to 85.5%. So if you look at prior chemotherapy arm, you are actually improving their chance of being disease-free at 5 years. Keep in mind, the no chemotherapy arm are traditionally the better prognostic feature arm. So if you have a premenopausal women who are node positive, who have a larger tumor size, you'll be inclined to give them chemotherapy, right? So then that patient will fall in the right side of the column, the graph, that they would be the one who may benefit from adding ovarian function suppression or switching them to exemestane. What about very young women, less than 35? About 11% of the trial had 350 patients were under 35. When you looked at it, that is overwhelmingly 94% of these patients actually got chemotherapy, which means they are predominantly the high-risk group. Now, this is going to be very important. Look at that. Tamoxifen only, 5-year survival without breast cancer-free survival, 67%. Tamoxifen plus OFS, 78%, 78.9, that's 79%. So you're adding 12 percentage points. Now think about it. Exemestane plus ovarian function suppression, 83.5%. So you're adding 16%. So this is dramatic gain in benefit, okay? So in very young women, which is traditionally the poor prognostic factor group, adding ovarian function suppression and switching them to exemestane gains a lot. And at 8-year mark, it showed similar results. I'm going to rush a little bit here. Now we look into the text trial. The text trial looked at the same thing, and they had the benefit of having additional patients. So the text and the soft trial looked at combined joint analysis. So they looked at tamoxifen plus OFS versus exemestane plus OFS. And what it showed was, in all attributes except overall survival, it's a little too early to understand overall survival, there was significant improvement in adding exemestane to premenopausal women who were undergoing ovarian function suppression. And again, if you look at it, prior chemotherapy versus no chemotherapy, there is significant benefit with prior chemotherapy. Okay, so moving on to another trial, ABCSG 12 trial. Now this is important because for clinical practice, this would bring out the nuance in breast cancer management. Okay, this was a trial that looked at tamoxifen. All patients got OFS. All patients are premenopausal. These are traditionally the good risk patients. One group of patients got tamoxifen. The other group got anastrozole. And what did that show? No benefit with adding an AI. But interestingly, if you look at the hazard ratio, the second part, overall survival, there was a risk if you put patients on anastrozole. And the question is BMI a factor? Now, this was done in Europe. There were a lot of patients who were obese. So you take premenopausal women, you suppress their ovaries, you give them AI, but if they were obese, are we actually suppressing their ovaries adequately by giving them GnRH agonists? There is a possibility that you may be giving them GnRH agonists every 3 months, but they are probably getting some resurgent endocrine function. So BMI is something that you've got to be very cautious about. And that is what this study showed. This is the soft test trial, which is a sub-study, and it looked at estradiol levels. So after my talk, if you decide to put some patients on GnRH agonist, if they are premenopausal, be very cautious. You may feel that they may not have menstruation. You may feel that you are giving them ovarian suppression, but really 1/3 of those patients are actually having a resurgence in their estradiol level. Read this trial when you get a chance. Okay, this is very important. Soft S trial. So be very cautious. So what is the best way to take care of these patients? You've got to monitor their FSH or estradiol level. I would say FSH is not very useful in this kind of setting. The estradiol level every 6 months. If you actually decide, because you may be thinking you are actually suppressing their endocrine function, but 1/3 of their patients actually have recurrence. So this is where the modality of ovarian suppression also comes into being. Are you going to just give them GnRH agonist, or are you going to just remove their ovaries? Keep that in mind, because removing the ovaries is the easiest, but the trouble with that is you can't give the ovary back. If they have bad side effects, you can just put the ovary back into their body. Hey, I'm going to give you some estrogen back, right? So be very cautious. So what I do is I always trial patients on GnRH agonist to give them a sense of what it means to have complete estrogen blockade. If they can handle it, then I talk to them about ovary removal. If they can't handle it, then I know that there is no point removing their ovaries. They're going to have a miserable life, and I have a discussion. So what do I talk about all of these? All these trials showed that patients actually gain benefit if they are premenopausal women. If you add ovarian function suppression, they gain more benefit if you add exemestane or anastrozole to the ovarian function suppression. But be careful about tolerability. Be careful about resurgence of the estradiol. So what are things that I'm talking about here? Remember, not all women need chemotherapy. We have a lot of options that would improve a patient's outcome. We have Tamoxifen extended trials. We have Tamoxifen followed by AI extended trials. We have OFS plus Tamoxifen trials. We have OFS plus AI trials. For really low-risk women, I think just Tamoxifen for extended duration, if they can tolerate it, is more than sufficient. So who do I consider ovarian function suppression? Those who receive chemotherapy, which means I have considered them as high risk. Those who have a lot of positive nodes, they are like stage 3 disease. Those who are really young, then in these patients, I actually consider adding ovarian function suppression. Now, quickly, impact of adherence. This study from Kaiser Permanente, big insurance cohort, showed that if a patient is 90% adherent, the chance of cancer coming back is 1.04, null. If they are 80% of the time, if out of 30 days in a month, if they take the pill for 25 days, there is a 50% higher chance for the cancer coming back. Now take this with a pinch of salt. I just want to convey the information to you. If they're taking it only half the time, you have a 3-fold high chance of recurrence, okay? So whenever I see a patient on follow-up, breast cancer woman who is on endocrine therapy, I ask them, are they taking the medicine? They may say, oh, I am taking it, but be very careful. So what I ask is, I don't ask them, are you taking your medicine? Because then they would say, yeah, yes. I ask them, in the last 30 days, how many days did you forget to take the medicine? And then they are very honest. Then they would say, about 2-3 days, 5 days. Then I would know. Then I can counsel them accordingly. I can see when patients say, I take it every day without fail. Okay, then I applaud. And if I can then assess the adherence and the discontinuation. This is very challenging. So what has now changed in 5 years? In the year 2020, what has changed? Tamoxifen is not anymore the drug of choice. We can use AI. We can switch the strategy. We can extend the therapy. In high-risk women, we can give ovarian function suppression. If you guys email me at Dr Aju Mathew at gmail.com, DrAjuMathew@gmail.com, I'm happy to share the slides. Please let me know. Now I'm going to ask you a question. This is a homework. I want all of you to participate in this test, okay? So you are going to see a 38-year-old premenopausal woman. Take a piece of paper and a pen because you're going to give answers to yourself. You don't want to give me an answer. Think about it yourself. A 38-year-old premenopausal woman, stage 3 breast cancer, right-sided. She's undergone lumpectomy. 5 out of 12 nodes are positive. Grade 2, ER strongly positive, PR negative, HER2 negative. Okay. Out of 0 to 100, what is the chance this woman would be free of breast cancer at 5 years if they just do lumpectomy plus radiation? Have a calculation in your mind. Have a percentage. Ready? Okay. So this is premenopausal, 38-year-old, stage 3, ER positive, PR negative, grade 2, HER2 negative, stage 3, 5 out of 12 nodes. Patient undergoes lumpectomy and radiation. If they just go from your clinic, if they abscond, if they don't come back, what are the chances they'll be breast cancer free at 5 years? Give a percentage in your mind. All right. Now, I'm hoping you would consider giving chemotherapy to this person. Okay? You add chemotherapy. You give them the best chemotherapy. How much more can you extend their survival rate? Write that down. That would be option number B. Okay. Now, this patient got chemotherapy and now she's back to you in clinic. You are giving them tamoxifen for 5 years. What is this patient's breast cancer free interval at 5 years? What is the chance this patient is breast cancer free? Keep that in mind. All right. Now, this patient comes to you after chemotherapy. You give them tamoxifen, but you add ovarian function suppression. What is the chance that this patient will be breast cancer free at 5 years? Ready? Okay, last question. Now you give this patient chemotherapy, patient comes to you, you give them ovarian function suppression and put them on AI, letrozole or anastrozole or exemestane. What are the chances this patient actually will be breast cancer free at 5 years? Ready? All right. Now I want you to subtract option E minus C. That is, you add AI plus OFS. And what is the absolute benefit with what you wrote for tamoxifen only? I want you to calculate what is the absolute benefit if you add tamoxifen plus OFS versus tamoxifen only. So option D minus C, option E minus C. Ready? Okay. Now I did this study 2 years ago. I sampled oncologists across the United States, and I asked them this question, and imagine what the average was. This was published in Annals of Oncology in 2017. So if you just Google my name and Annals of Oncology, you'll get the study. Most oncologists said the benefit gained with adding ovarian function suppression to tamoxifen was 3.4%. Do you know what the trial showed? Adding tamoxifen plus OFS was about 5%. So they underestimated. But what's important is adding an AI to the OFS. Most oncologists estimated the benefit, absolute benefit at 6%. The clinical trial showed that, in fact, most recent study from the soft and the text trial showed that if the patient is the similar characteristic that I talked about, the absolute benefit is 15%. So the biggest barrier to getting optimal treatment for women premenopausal with breast cancer is not cost of care, is not treatment, it is us oncologists. We love our chemo, we give them a lot of benefit with the chemo, but actually we don't pay much attention to the benefit that patients would get with hormonal therapy. So this is 100 oncologists. Some of them are very top class academic oncologists who were sampled, and they underestimated the benefit of endocrine therapy. A lot of what I talked about is available in this review. This is a little outdated 2015, but it covers a lot of what we talked about. This is in the Breast Journal. This formed the consensus for the St. Gallen conference. Now I'm happy to answer questions.
Thank you very much, Aju, for a very crisp review about endocrine management of premenopausal women. I think we will set the stage open for everybody to ask their questions. Please feel free to type the question in the chat, or if you want, you can unmute your audio, ask the question, and then mute it again.
Good evening. Can I ask one question? I am Dr. Chaturbuj Agrawal.
Yes.
So my question is, once we have given chemotherapy, and before starting, suppose if same patient profile which you have shown in the last slide. So same patient profile, node positive, young premenopausal woman, we have given dose dense chemotherapy. Then she comes to us, and for example, we do a E2 level. This is postmenopausal. So we start her on endocrine therapy. So this could be chemotherapy induced menopause. So how frequently we are supposed to monitor E2 level in this case when she's on endocrine therapy? We are giving GnRH agonist, and how reliable is E2 level in monitoring such patients where we are expecting chemotherapy induced menopause, but we are giving endocrine therapy also?
Excellent question. Now there is an excellent review article written by, can you hear me everybody? There is an excellent review article written by Mitch Dowsett, Nance Davidson et al. For JCO, I think a year ago, 2 years ago. Very good question. So if that patient has achieved postmenopausal level, E2 level, estradiol level, I don't add a OFS then. I just, if the patient is willing, they are high risk enough, I start AI. I monitor their estradiol level using high sensitivity test every 6 months, and also keenly watch for recurrence. This is a very contentious topic. This is where you really have to talk to the woman, but I don't start a treatment and not forget to check their estradiol level. Keep in mind, I do it every 6 months if a patient has already achieved chemotherapy-related amenorrhea, because they could have recurrence any time. Younger the woman, they could have a recurrence. So very good question. I monitor estradiol. Now, how sensitive it is? When I actually started ordering it, there was a high sensitivity test as well as I don't know what the other test was called, just the ELISA test. It was dramatic, the difference. So the LCMC test, the liquid crystallography mass spectroscopy, whatever that is, that test is the most sensitive. So I would be very cautious with ordering the high sensitivity estradiol test. I use it every 6 months. Let me answer a question here. So any subset in which you will consider tamoxifen beyond 10 years, is there any extra benefit? Excellent question. Now, Dr. Pao, I believe that's his name, Gao Pan from the NSAPP collaboration, they did a meta-analysis and published their results in NEJM 2 years ago, looked at 20 years risk of breast cancer. We know that higher the risk, higher the stage, the higher the risk of recurrence, and is out of our mind. Patients have higher risk of recurrence at extended point of time. But keep in mind that most of that risk may not be distant recurrence. Most of them may be a second breast cancer. So current evidence stands for 10 years. But to be very honest, doctor to doctor, confidentially within this group, if I have a loved one and that loved one has very high risk, stage 3, 28 out of 28 lymph node positive, we know that they have metastatic disease. I would probably continue. I don't know. Tolerability would be the key factor. I don't know. This is very tough question. Standard of care, 10 years. Is there any extra benefit? I'm not expecting any trials, but why wouldn't it benefit? Okay. But this is not an answer for your test questions, okay? This is a very clinical practice, taking care of a patient, shared decision-making, understanding. This is data-free zone. Be careful. Next question. In switching from tamoxifen to AI, how to check menopausal status, history or by estradiol level? We'll give you a very good quick example. Just 6 months ago, a patient came to me from another sender. That patient had recurrence of disease, pleural nodules, and bone metastasis. She was about 52 years of age, 51 or 52 years of age. About 1 year before she came to me with the metastatic disease, the doctor had switched her from tamoxifen to AI, assuming that she's now 51 or 52, she's postmenopausal. She was amenorrheic after chemotherapy. The first thing I did was I checked her estradiol FSH level. I checked it twice. Remember, you have to check it twice, 3 to 6 weeks apart. Just one check is not sufficient to switch patients from tamoxifen to AI. Check it twice. This is not, I'm not making it up. This is all there in the literature. So when I checked this patient, she actually had menses. She actually had estrogen production. So it is very possible that that patient had recurrence because of being on an AI in the setting of ongoing estrogen production without menses. Okay, so check it twice, both times consistent result, then feel free to switch them. Then the question comes, how much more years would I check their estradiol level? 52 years, the average age of menopause here is in India is about, I think, 53 or something. I would do it for another 2 years, 54, if they can afford. Now, all of this is provided they can afford it. There is an affordability equation, there is a cost of care. But, you know, I would err on the side of caution. If I'm switching a woman to an AI, I would be cautious. Please be very cautious. Next question here. Can you please explain significance ER positive and PR negative and vice versa in a treatment decision? Excellent. ER positive and PR negative is a reality that can happen. ER and PR are both prognostic factors, but PR is both ER and PR are also predictive factors. So if ER and PR are positive, good prognosis. If ER and PR or PR are positive, predict for benefit for endocrine therapy. Okay, I'll stop there. Now, PR, if it is negative, it is a prognostic factor for poor performance, poor benefit, poor risk. PR, if it is negative, it is a predictive factor for less benefit with endocrine therapy. And that's what the luminal beat is all about, right? But coming back to the other question, what about PR positive, ER negative? This is a very contentious topic. Again, I refer you to JCO commentary. I forgot the author. The title, I think, starts low ER and PR positivity, ER negative, PR positivity. Does this exist? Keep in mind that multiple centers of higher excellence have looked at it. And in their studies, they have seen that only about less than 1% of patients are PR negative, but ER negative, but PR positive. Are ER negative, but PR positive. So if you see a result, ER negative, PR positive, talk to your pathologist, talk to your surgeon. Did your surgeon actually fix the tissue in time? Is the cold ischemia time appropriate? Was the ER/PR done on a mastectomy specimen, or was it done on the biopsy? Remember, biopsy is ideal, okay? Not on mastectomy. Why? Because mastectomy, it takes time for the fixation to happen. I mean, good centers do it very, very fast. Cold ischemia time is less than 30 minutes. So that is one of the major reasons for this ER negative, PR positive status. If it is truly ER negative, PR positive, you trust your pathologist, you trust your surgeon, you trust whatever result you've got, then I would be cautious. I would still give them the endocrine therapy. But if they have tolerability issues, I would stop it. And I would assume that it really has no benefit. I hope that answers your question. Now let me just go back to answer some other questions. I've got a bunch of questions here. Let me take the next one. Dinky Gajwala. For which group of patient you consider OFS with tamoxifen versus OFS with AI? Very good question. OFS with tamoxifen, premenopausal, young woman, almost all except stage 1. Okay, they have to be hormone positive. I'm not talking about triple negative. Hormone positive, except for stage 1, I do think about OFS, adding the OFS to stage 2, stage 3 patient. Now, when would I think about stepping it up and switching them from tamoxifen to an AI? Very difficult question. Why? Because I know that adherence is challenging. I know that tolerability is challenging. You know what their major side effect is? Vaginal dryness. Significant sexual side effect. It's bothersome for young women. You got to think about that. What else? Bone pains, bone disease, cardiovascular disease. You got to think about all of those questions, okay? You got to think about all of those things. So who do I think about adding an AI? Stage 3 disease. N2 disease, I think about adding an AI to an OFS. Again, cautiously. But the patient should also agree. Now, here's where I make the very important clinical decision making. I don't immediately change patients from, I hope you can hear me, my internet connection is unstable. Okay, anyway. Can you hear me guys? Okay. I don't immediately change patients from, I don't immediately start patients on AI. I'm very cautious. I start OFS, I start patients on tamoxifen. I give them 3 months of OFS for two benefits. One, that's approximately time it takes for us to suppress their ovarian function. Two, I get their body some time to adjust so that I can actually assess their response, tolerability. And then only I talk about an AI and make that change. So I don't immediately change them to AI plus OFS. I give them some time to understand what it means, what the side effects are. A lot of the patients already immediately say, I can't handle this. Also, I give them at least 3 months for the ovarian function suppression to kick in, okay? Unless I'm actually plucking out their ovaries. Surgical ovarian ablation is easy. Then you know you have ensured complete ovarian suppression. You don't have to worry about testing their estradiol level or anything like that, okay? All right. Gunjan Srivastava, how to ensure bone health for patient on AI. Now, I have published plentiful papers on this, on adjuvant zoledronic acid. If you look at my reference in Lancet Oncology, you see a lot of papers on this topic. Bone health is very important. If I put a patient on an AI, I always check their baseline bone density scan. Why? Because that's going to be a key factor for me to assess their tolerability 2 years from now or 1 year from now. How do I ensure bone health? I make sure they get calcium, 1000 milligrams of elemental calcium. In our India, we call it Shell Cal 500, 2 pills. I ensure at least 400 to 600 units, international units of vitamin D. Shell Cal 500, Shell Cal HD would have what you need. So I make sure they take that, 2 pills a day. Okay. For some patients, I may consider adjuvant bisphosphonate, not for the bone health, but for disease recurrence risk reduction. I know that adjuvant bisphosphonate have about 2 to 4% absolute benefit, almost as similar to an anthracycline, okay, adding an anthracycline. So I don't add bisphosphonate for a young premenopausal woman at the get-go for their bone health. I think about it for their disease risk reduction. Who do I think about it? Stage 3 women, predominantly. I hope that answers your question, Gunjan. Now, Ravi, hi Ravi Jaiswal. Oh, I think I answered your question. ER positive, PR negative. Okay, Rohan, do you check for endometrial thickness in an asymptomatic lady on tamoxifen? I don't. There is no recommendation for that. Does it matter? It doesn't matter at all. There is no role with endometrial thickening. Why do I say so? What are the chances for endometrial cancer, endometrial hyperplasia if you put a patient on tamoxifen? If you put them on ovarian function suppression, then it's okay. If you just put them on tamoxifen, what are the chances endometrial thickening can happen? In premenopausal women, it really doesn't matter. There's no higher risk for endometrial cancer. In postmenopausal women, that's where you have to be cautious when you give tamoxifen in postmenopausal women. So if you're ovarian function suppressing and you add tamoxifen, do I check endometrial thickness? I don't. There's no recommendation globally. In fact, we wrote the breast cancer guidelines for the Kerala state. And in that, we specifically wrote not to check ultrasound regularly to look for endometrial thickening, because stage 1 endometrial cancer is easily curable and preventable. Stage 1 endometrial cancer is easily diagnosed. Endometrial cancer is easily diagnosed as stage 1. Now, what are you going to find? Now, a lot of women will have endometrial thickness. Does that mean they're going to have cancer? No, we just don't know. So what I tell women is, if you have spotting, don't delay. Come see me. So spotting, vaginal symptoms in a woman who's ovarian function suppressed and on tamoxifen, that's what prompts me to do ultrasonography. So otherwise, I do not. And I don't think any guidelines actually talk about doing it. If I am wrong, please correct me, but we just need guidelines for Kerala State and remove it from the guidelines. Samir Srirangava, do we need to stop tamoxifen or AI before sending estradiol? Remember, the test you got to send us is not estrogen, it's estradiol, E2. Estrogen and FS level, if yes, for how many days? Do we need to stop tamoxifen or AI? No, you don't have to. Just take it. I prefer early morning sample, 8 a.m. sample. Is there any science to that? I don't think so. You can take it anytime. But you don't have to stop tamoxifen or an AI to send estradiol and FSH levels. Keep in mind that the FSH level in postmenopausal women are traditionally high, but if you put them on GnRH agonists, they would be low. So keep that in mind. So FSH alone would not be a good guide. I think that's why estradiol would be very important. Gunjan, I think I answered your question on bisphosphonate as an adjuvant therapy. Yes, I do use it in higher risk women. I don't use it for stage 1 breast cancer patients. I do consider for stage 2 hormone receptor. I definitely consider it for stage 3 hormone receptor breast cancer. Because 38 years, PT1N1, luminal B, post 3 FEC, 3 docetaxel, post RT. What do I consider? 38 years, this is stage 2, adequately dissected, lymph node sample, so N1 I believe is accurate. Luminal B, post chemotherapy, this would be the sort of classic patients who would fit in the SOFT and the TEXT trial. This is the sort of patient who would benefit from ovarian function suppression. Now, whether you want to give tamoxifen or whether you want to give AI, that is for you to have a discussion with the women. What is the difference going to be? Overall survival, not very high. There could be a disease recurrence reduction. Overall survival, we don't have data. I don't think it's going to be very high. But could there be a quality of life difference? Yes. So T1, N1, you will have to bend my arms, force me, point a gun at me or a knife into my abdomen to put them on AI. I would strongly consider OFS plus tamoxifen, but AI I would consider if patients have N2, N3 disease. If let's say 13 out of 13 nodes are positive, 10 out of 15 nodes are positive. I hope that answers your question. Oh, I'm sorry, that was a private question. Sorry for seeing me. Now, Cherian, hi Cherian. You prefer 3 monthly or monthly LHRH agonists? I prefer 3 monthly leuprolide. I think the dose, I used to give 22.5. Cost is prohibitive. So I have sort of started to give 11.25 milligram depot injection leuprolide. I think that's appropriate. I know from a lot of trials that are coming out in the setting of adjuvant chemotherapy, ovarian function suppression, that dose is sufficient. So I think I would go with that. What if the trials use monthly goserelin and monthly triptorelin? I think it's not fair for our patients here to have them come back for monthly injection. I don't want to do it if I was going to get it monthly injection intramuscularly. So 3 monthly is my choice. Leuprolide, I would go with, I think 11.25 for most women. Depot injection. A private question, what next, tamoxifen or AI plus OFS or TAM plus OFS? Okay, I answered your question already. It is, I would give that patient T1, N1, 38-year-old luminal B, post-chemotherapy, post-RT. I would give tamoxifen plus OFS. I would not consider AI because of tolerability issues and because of lack of overall survival at this point in time. Is there any difference between tamoxifen 10 milligrams twice daily versus 20 milligram once daily? Really, no data. I give 20 milligram once daily. I think I can ensure better compliance. I don't think there is any difference in efficacy or effectiveness. I don't think there is really any difference in tolerability. I think it's all about compliance, about remembering to take. So I go with 20 milligram once daily. Sneha, is there any role of GnRH before starting chemotherapy in premenopausal women when we are planning for AI plus OFS? GnRH has very good question. Now, why would you actually give GnRH before starting chemotherapy? It is to basically protect a woman's ovarian function. Why would you want to do it? In a young woman, if let's say they want to have another child, in a young woman, let's say you want to prevent them from being amenorrheic. Let's say you want to maintain them from maintain them from having estrogen function. So let's say, you are giving adjuvant chemotherapy for a N1 disease, like the patient that somebody just asked me about, 38-year-old premenopausal woman. If I was going to give that patient ovarian function suppression so that they have their endocrine function recovered, then why would I give them ovarian function suppression after their chemotherapy is over? You understand the point? So the only reason most women get, I'm not saying most women, currently some guidelines actually talk about advising GnRH agonists for patients who are on adjuvant chemotherapy is for fertility preservation. Now, what I'm talking about is, I'm not even thinking about fertility. I'm talking about risk factor recurrence, right? So there is no role for GnRH before starting chemotherapy in this setting. Preeti. Hi, Preeti. In premenopausal women on tamoxifen complaining of menorrhagia a few months after chemo amenorrhea, do you consider stopping tamoxifen? Okay, very good question. Chemo amenorrhea. Let's say the patient has got chemotherapy, they are amenorrheic, and they are on tamoxifen, and then they have menorrhagia. Do I stop tamoxifen? I think this is where I need to talk to my gynecology friends. I would definitely send that woman for an evaluation, probably endometrial curettage and biopsy, to see if they have hyperplasia, atypia. If so, then I would consider stopping tamoxifen. Again, here's where I need to understand the risk of the disease recurrence versus what is the need for having the uterus. Is the uterus dispensable for this woman? Can we just remove the uterus and continue tamoxifen? Does this patient absolutely need endocrine therapy to be alive? Then I would discuss with my gynecology colleague and talk about, and my patient, and talk about removing that the uterus. Shayada, private. For postmenopausal women on AI, do you use bisphosphonates for bone health? Postmenopausal women on an AI, do you use bisphosphonates for bone health? I don't. Do I use bisphosphonate for risk reduction? Yes. Stage 3 breast cancer patients, postmenopausal women. Stage 2 breast cancer women, postmenopausal. I do consider. Stage 2 I consider. Stage 3 I recommend bisphosphonate. What is the dose I recommend? It's in my paper in Lancet 2015. It's the editorial for the ABCSG meta-analysis. I recommend zoledronic acid for every 6 months for 2 to 3 years. 4 milligrams IV every 6 months for 2 to 3 years. Do I give bisphosphonates like it was done in the ZOFAST and the ZFAST trial for bone health only? No. But I do monitor postmenopausal women with DEXA scan at baseline, and then I check it about a year or 2 years, ideally 2 years later, provided the woman is compliant on calcium and vitamin D. If at 2 year mark, if the patient was normal at the get-go, at 2 year mark, if they become osteopenic, then I would consider bisphosphonate. If they become osteoporotic, then I do give them bisphosphonate. If at the baseline, if they are osteoporotic, I give them bisphosphonate. If at the baseline, they are osteopenic, I consider, or rather I give them bisphosphonate. I hope that answers your question. Because any subset of patient to give AI more than 5 years? No, I don't think so. Yes, sorry, there is a subset of patient. Yes, more than 5 years, postmenopausal, N2, N3 disease. At 5 year mark, no toxicity, or rather minimum toxicity. What is the toxicity? Their bone health is fine. DEXA scan looks clear. I do get a DEXA scan at that point of time. No osteoporosis, no osteopenia. They don't have much joint problems. They don't have multiple cardiac events. Those women, I give them additional 2 years or 3 years. Then I evaluate them at that 2 year mark again. I check their bone density scan at that point of time. And then I decide I'll extend it further. So cautiously I'll extend it. Because we know that most postmenopausal women, if they have already done AI for 5 years, they get benefit, additional benefit even after they stop for an additional 4 or 5 years. We know that from very good data. There's meta-analysis data that most women gain benefit, durable benefit, additional benefit even if they stop the treatment. So let's say a 70-year-old woman is here. The life expectancy is only 75 or 78. I stopped the AI because, what is going to happen? The breast cancer may come back at 75. The patient was anyway going to have poor prognosis in terms of cardiac health. So I keep all of those factors. Rohan, any premenopausal subset where fulvestrant is preferred? No, I don't use fulvestrant at all in an adjuvant therapy setting at this point of time. We don't have much trials also that are currently ongoing. I think most investigators think that fulvestrant is overdoing it. Current trials are all looking at CDK4/6 inhibitors. I myself was in fact, I had the first patient recruited to one of those trials in North America into palbociclib. That patient was stage 3 breast cancer, N3. Patient absolutely did not want chemotherapy. We randomized her into palbociclib plus AI plus OFS versus AI plus OFS. Patient fortunately got palbociclib for 2 years. She's just about taking the 2-year mark. She's fine up till now. So I think we'll have more data on adding CDK4/6 inhibitor in high risk setting, but not fulvestrant. Dinky Gajwala, hi. Very young lady, less than 35 years, not completely completed family, and wishes to plan pregnancy. What to advise when to plan? Wow, that is a tough question, very tough. Okay, less than 35 years, T1, stage 1, I would give them at least 2 to 3 years of tamoxifen. Then I would talk to them, counsel them, give them a break, allow them to become pregnant, deliver the child, then cautiously reintroduce, provided lactation is acceptable after lactation. Very tough. In fact, I haven't had to contemplate this question in a long time. So I'll have to look into literature again. Very complicated. Now, let's say N2, N3 woman, less than 35, want to have a child. Very challenging, very challenging. That woman, I would give them the GnRH agonist before I start chemotherapy. I will try to cryopreserve their egg. I would still try to give them the GnRH agonist. I would take them through the chemo. I hope I'll keep them the tamoxifen for a couple of years. I'll talk to them, tell them of the risk, and maybe use the cryopreserved embryo. And we know that IVF is okay, is acceptable. There are guidelines if you want to look into ASCO, ESMO guidelines on this topic. And then I would cautiously take them through this process, and very challenging. In fact, I've never had a patient who wanted to have a child in all these years of practice, because they overwhelmingly fear the cancer more than having a child at this point of time. But this is a practical question. This can happen. I'm sorry, I'm not an expert in this. I think that is the end of all the chat questions. Anything else on over audio?
I think we're probably done with. Looks like it was, I think, very good interaction. I myself enjoyed. So I hope Aju, you also probably it looks like you enjoy the interaction with these students.
Oh, I love teaching. I was a program director. I miss teaching now, so I always like to teach. Thank you. Thank you for this opportunity, Padmaj.
Yeah, I will look forward to having you sometime again later this year or maybe early next year. Till then, I think goodbye and we'll see you. Good night.
Thank you.